we ran a trial which randomized patients between standard total dose radiation and a dose that's about 22% higher. We were hoping to see a survival improvement with the more intense radiation, and we had good pilot data to support that. Well, what the study actually showed is that the higher dose of radiation was associated with a poorer survival than the standard dose. So we spent a lot of time trying to understand why that happened. We do believe that the dose to the heart, which is not a target organ, but the incidental dose to the radiation dose to the heart, was associated with a higher risk of mortality. That's led us to really think about how we plan the delivery of radiation better, reducing the dose to the heart. And it's also given support to a new phase 3 trial we're running, where we're comparing the conventional dose and the conventional approach with radiation and chemo to a higher dose of radiation with chemo using proton therapy. Proton therapy is a new way of delivering therapy where we do have the ability to target better. And I think we've demonstrated in a number of studies we can reduce the dose to the heart in that. So that was how I started. Some other ways that we're trying to improve radiation include using PET scanning, not just to stage a patient, but also as part of the treatment planning process. Another thing that gave us pause was an analysis of that study I mentioned where the higher dose of radiation was associated with poor outcome, where we actually looked at the patients according to what centers they were treated at. Was it a center enrolling a lot of patients or very few? And we found that the patients enrolled at high accruing centers had longer survival than those at low accruing centers. So this is a pretty profound observation, and what it really tells us is there's perhaps more of a learning curve of the teams taking care of these lung cancer patients than we realized. There's probably more need for education, more need for process. That type of observation's been shown before in surgery, both in cancer and non-cancer settings, but I don't recall a recent observation of that in the non-operative management of a disease like lung cancer.